Hi everyone and welcome to the channel. I'm Professor Okun from the Life Science Faculty at Bar-Ilan University, and today I am interviewing Professor Richter-Levin from the Psychology Department as well as the Neurobiology Department at Haifa University.
Sagol Department of Neurobiology.
Sagol Department of Neurobiology, it's important. That's where the money comes from. I'm very happy to be here, finally.
I'm very happy that you're here as well.
After a long while that I haven't met you in a long while, and it's been the Corona year or year and a half that we didn't get out of the lab or the office to see other people. So you're an expert on stress, how stress affects our biology in health and disease. And today I want that we will talk about how stress affects us, both acute stress, chronic stress, etc. Okay, so that's what our podcast today will be about. It's going to be very interesting, so stay with us. I prepared some questions for you. So first of all, Gal, can you tell us what is stress?
You know, there have been something like 60 years of efforts to define stress, but I will try to give a kind of description, not a definition. Just this week, a paper of ours was accepted which talks about semantics, about the differentiating between stress and trauma.
Oh, okay.
Because the problem with the term stress is that it is actually used for describing both mild stressors, which somehow affects us emotionally, but does not have any negative impact or long-term impact. And you have stressors which have long-term impact, but we cope with them. We manage, and we have a lot of those in our life.
So give me an example for what is a mild stress for you and what is the more impactful stress.
What is complex and beautiful in that is that it is very individual. But in principle, we know that if I drive and there is a traffic jam, it can annoy me a lot. And if I'm in a hurry to a very important meeting and I am afraid that I would be late to it, it can stress me, seriously stress me, but it is not likely to bring to any pathology.
Okay.
To lead to any pathology, right? Whereas if unfortunately I have a car accident, a serious car accident, I may even develop some kind, in addition or even without any physical wounds, I may develop some kind of psychopathology.
Okay.
As a result
Which is long term.
Which is a long-term change in my system. But if I was in a car, in a traffic jam, and I'm late for a very important meeting, I may also have long-term effect. I may learn to go out earlier so that I would not position myself in such a situation. So it's not just that it is long-term, it is long-term and pathological. It means that it harms in some way the physiology of the body. So stress as a term ranges from some kind of emotional effects to stressful effects which we can cope with, to traumatic effects which actually damage our physiology in some way.
So if I can sort of summarize, both types of stress induce learning for us, but learning, these different types of learning can be in a way either a positive sort of learning not to be late next time, what should I do in order not to be late, or a sort of a negative kind of experience or learning, which is in the case of car accident, it will leave a mark on me and will change my behavior.
Learning is a very significant part of what happens, learning and memory formation, and it can be positive learning, which helps me adapt a more coping behavior for later on challenges. It can be kind of pathological learning. If I start to be anxious going out and not being able to go back to driving or something like this. But learning and memory is not the only thing that happens. it's a kind of or if you want, it's a kind of an emotional memory that can be created, and again, it can be an emotional memory that serves me in a positive way, or it can be an emotional learning that actually disables me from being able to meet challenges later on in life.
Yeah, so let's try and focus now on that part, because that's what we're concerned of. And by the way, the idea to this particular episode of the podcast, came up in the recent sort of clash between Hamas and Israel, and we know that there has been a lot of stress to a large portion of the population. And I wanted, towards the end of this talk, we will better know what are the kind of adverse or negative impacts of this kind of stress on our health. So let's start with asking, so stress can be either short-term, acute, or long-term or chronic. So what are the chronic effects of stress, like a prolonged stress? What should we expect to suffer from?
I'm sorry, but this is also a bit complicated. So you have first of all, you can have acute stress, which is something that is very sudden and happens on a short window of time, but it can be very strong or it can be milder. And you can have chronic stress, which is long, but it depends on the nature of it as to what the outcome could be, because you have two competing actually processes. One process is the learning, the adaptation of coping strategies, and so the ability to build up preparation for the situation, so that in fact you may be even more resilient following a chronic exposure. And the opposite is that it actually affects you in such a way that it actually disrupts your coping abilities, and so you are more and more affected by the situation and you develop pathology. And when I say you, it is very individual. Some people grow from such experiences. Some people actually may have a very negative outcome.
So I want to touch about that later on, when we try to understand who is more susceptible or who can be more affected. Can we know who these people are? But let's just if you can tell us, what should we expect from having this long-term stress or chronic stress? For example, if we are undergoing several weeks of stress from the danger of missiles, on our homes, for example, what should we expect? What are the kind of pathologies?
The pathologies now have a kind of their own category of stress and trauma-related psychopathologies, which include post-traumatic stress disorder, or PTSD, which include post-traumatic depression, which can include some behavioral pathologies, which do not fall exactly to these categories, but not being able to be part of a school discipline or things like this, which make your ability to learn being impaired by such experiences. So you have again a range of pathologies. The most associated with pathologies is post-traumatic stress disorder, or PTSD, and post-traumatic depression.
Okay, so PTSD and depression. So when you say post-traumatic depression, do you mean depression as we know it, the typical?
We talk about major depression, which is like the classical depression, which may not be dependent on exposure to stressors or trauma or so. And we talk about stress-related. The symptoms are very similar. There is a debate or discussion about whether the mechanisms behind the responsiveness to treatment is similar between these two conditions. We do not yet know.
Okay. So maybe there are some different genetic factors to both?
A psychiatrist once told me, for example, that with major depression, some people may completely recover from symptoms by drugs like SSRIs, whereas with trauma-related depression, you may see improvement, but you would never see complete. Yes. So they assume that there might be some difference, although the symptoms are very similar.
Okay, so you mentioned PTSD and depression, which is stress-induced depression, not other types. So let's focus a little bit about PTSD. Or you know what, we can also include depression now. Who can actually diagnose this condition? So
the diagnosis tools we have available now are not excellent. And in fact, these are more kind of legal definitions, because you know, if a system like the Ministry of Health or the Ministry of Defense want to define who they are supposed to support or something, they need a legal compensate or something, they need to have a legal definition of this person is diagnosed as suffering from PTSD. Why am I saying that? Because a legal diagnosis is done by psychiatrists.
So
psychiatrists can diagnose you as suffering from this disorder or that is psychiatric disorder, but this is all based on behavioral symptoms and interviews with the patients and so on. And these are not objective, categorical definition.
So it's not biological sort of indicators that you have a situation like a depression or PTSD?
Not at all. This is our hope, this is our aim, to create a kind of biologically based diagnosis, but we are not yet there.
That's amazing. 60 years and we don't have a biological indicator for these conditions.
There is no biological indicator for any of the psychiatric disorders. We have to differentiate between two types of biological findings. You have what I call statistical findings, because you have papers, you have chapters in books that describe the depressed brain, the PTSD brain, etc., etc. And we know brain areas, and we know some mechanisms that we assume are associated with the pathology. And these are based on findings. These are based on experiments and on findings using animal models, using humans and imaging and so on and so forth. And we think there is something in these findings. But these findings have not yet been translated to diagnosis. Diagnosis means that there's a person coming in, you send him to this test, and according to that test you can say you suffer from depression or you suffer. Because of the high individual variability, the disorders we talk about, PTSD or depression, these are actually clusters of symptoms. So one person can be diagnosed as suffering from depression, the other would be diagnosed as suffering from depression, but they do not exactly exhibit same symptoms.
So can we also in this case, as we know from autism, for example, can we also regard to PTSD and stress-induced depression as a syndrome?
It is considered a syndrome. It's a kind of a cluster of symptoms, and there is some variability as to which exactly symptoms someone would show, or which of the symptoms would be more enhanced with one patient or the other. And you could expect that brain mechanisms that are behind it would be somewhat different. That is why it is so difficult to achieve a clear-cut diagnostic finding.
Not even using imaging techniques. For example, we know that there are MRIs, PET scans, etc.
They are used in research.
Only in research.
They are used for the statistical findings, as I said. There are findings. As a result of those studies, we know of some brain areas that we know are more related to the pathology, so we can give a kind of a average description of mechanisms that are associated with the syndrome.
But it can't be used in order to say that person A has definitely PTSD or depression, etc.
Exactly. And I assume that because of this variability, there would be no single parameter or marker that could be as accurate as that. And we have now, in every field, we have the development of big data analysis, artificial intelligence analysis. So I assume that in the end, there would be something of that sort that would take a variety of variables from imaging, from blood measurements, etc., and somehow have an algorithm that would analyze those, and that may come to the level of being used as diagnosis.
So, in other words, you are saying that you hope, or the field hopes, that there will be a big data approach that will use perhaps artificial intelligence to take many factors that will be collected and then be able to say to a large extent whether a person has a condition?
The short answer is yes. A bit longer answer is we have really a very subjective phenomena here. The way any individual responds to stress is very, very individual. And we know that people exposed to trauma, no matter how severe the trauma would be, many of those people would not be pathologically affected.
So that leads me to my next question, next set of questions. Do different types of insults or different types of traumas induce different types of PTSD? For example, if a person is experiencing an armed robbery versus whether a person exhibits or sort of is witnesses sexual assault or any kind of other things, will the same mechanisms in the brain induce a similar type of PTSD response or different types?
So you have to separate between two things. It could be that by and large the same brain mechanisms would be involved, but they would be practiced on different cues from the environment. So that if you were sexually assaulted, then cues that would be associated with that would trigger those brain mechanisms, whereas if you were assaulted by robbery or violence, there would be cues that are associated with that would trigger probably quite similar mechanisms in the brain. So in terms of the neurobiology, you may have differences between, if we talked about acute traumas versus very long-term exposure like the Holocaust exposure, which really has very different effects than an acute trauma. But if you, to the best of our knowledge, as we say, we are limited with our knowledge, to the best of our knowledge, there's not such a big difference in the neurobiological mechanisms associated with different acute insults, but they are activated by different associations, different cues, etc. So they would appear and would affect in different contexts.
We mentioned PTSD as an outcome of chronic stress. We mentioned stress-induced depression. What percentage of the population is actually affected by either PTSD or depression as a result of stress?
The large majority of people exposed to chronic stress or to a traumatic event would not develop pathology.
So what is the majority?
It ranges from, normally in the general population they talk about something like 4 or 5%, whereas the chances of being exposed to some traumatic event or something is something in the range of 70 or 80%. So 70 or 80% of the population would have in some time in their life, at least once, in Israel it's a bit more, be exposed to some traumatic, really significant traumatic event, but only something like 3 to 5% of the people would develop pathology as a result. There are some types of insult that lead to higher percentage. For example, rape, and by the way, particularly when males are raped by males, but also women who are raped has a somewhat higher percentage of affected. When you talk about 20% of the exposed population developing, this is considered to be a lot.
Wait, so now I'm a little bit confused, because now you're saying that a certain type of a stressful experience, for example, rape, whether it is in the same by the same gender or different genders, leads to a higher rate of PTSD or depression compared to other types of stressors.
Yes, but I will refer to that in a second. But first, you should notice that still, even in those events where you talk about high percentage of affected individuals, you still talk about something above 75%, normally above 90% of the people exposed to those traumas that do not develop pathology. This actually means that the exposure to the trauma by itself, as such, is not a sufficient condition to induce pathology.
So what is needed to induce pathology?
You need some kind of predisposition, vulnerability, that together with the exposure to the trauma would lead to the development of the pathology. And when I said this changed my research, it's because it shifted my attention to looking into predisposing mechanisms and how they interact with the trauma exposure to lead to pathology.
So what are those factors that predispose us?
Of course, there are some genetic factors that could contribute to sensitivity. There are some kind of life experiences. Probably the most clear-cut factor that contributes to pathology later in life is some forms of childhood adversities. This is like the most consistent factor that is found to affect. You can see it in humans in every study that looked at it. When you compare the percentage of people who suffered from some kind of childhood adversity, who develop post-traumatic PTSD or post-traumatic depression, this is much higher than in the general population.
So just so that I understand, it is the fact that the trauma occurred during early years of your life will determine the most whether you will develop PTSD or depression. Is that the implication of what you said?
Would not determine, but would be a very significant factor that increases, and this is mainly childhood, by the way. When you say early life, it's a long period.
Childhood. So what is childhood for us?
Childhood is 5 years to adolescence. In adolescence, you are anyway bombarded with hormonal, emotional, and so on.
But just for the viewers, what is adolescence?
Adolescence is when you start puberty, when you start your sexual maturation, which is normally for girls it's around 10, and for boys it's around 12.
So 5 to 10 in girls, 5 to 12 in boys, that's sort of the window of danger.
The most significant. Earlier, later experiences could also be predisposing, But the most consistent finding is like that, and it is reflected quite a lot in animal models as well. This is not to exclude or to say that other factors do not contribute, because they do. Remember, there are also very proximal factors that could contribute. For example, you woke up in the morning, you had a bitter argument with your spouse, and you are all nerves, and then you encounter something, or you had a very nice day, very nice morning, you had a very nice conversation over breakfast, and you went out and you encountered something. This by itself could change the way you would actually perceive the experience that you've been exposed to.
So that's a context.
Right. And predisposing factors could actually affect your kind of proximal experiences and perception. So it is all, the complexity is that this is all interacting. I'll give you an example. We talk about genetic background. So people look for genes that are associated with PTSD, okay? But, you know, we are living in a hot country. Some of us sweat more than others, right? If I have a gene that causes me to sweat a lot, it means that for every experience I'm experiencing, I'm a bit more stressed than someone who sweats less. It's not directly related to the pathology, but it contributes to the way I would experience the experience, right? So this gene would have some kind of contribution. And if you accumulate such genes, you get to... So the search is not for genes that are directly related to the pathology, but which shape the way you experience the world. Which is, of course, much more complex to detect and...
You might be experiencing a traumatic event during your childhood years. We said earlier between 5 and 10 or 5 and 12, depending on whether it is girls or boys. And then you say, this was just a predisposing event. Once you had that predisposing event, and then when you're an adult, for example, you went to the army, or you experienced a car accident or a trauma, then you might develop PTSD at a higher rate.
So first of all, there are some children exposed to trauma which develop pathology by that exposure. As I said, it's very individual, and there is variability.
By the very initial exposure.
Yes. Mm-hmm. So someone lost a parent as a child. This may strengthen him. This may actually affect him in a very negative way, right? And there are so many factors that contribute to this, because it is not just a single exposure. You know, you lost your parent, and then how do your life look like? Some people suffered for something like that, a severe car accident as a child, loss of a parent, assault from others, or something like this, and they develop pathology. Mm-hmm. Some would not show any pathology, and they would seem to be normal, but they are more sensitive to the possibility of developing pathology if they encounter a kind of trauma later on in life. Some, by the way, may be more resilient.
Wait, we'll get to resilience factors. I hope I will remember that. But I just want to make like order in the... So we have the predisposition thing, factor in early childhood.
The only thing that I wanted to emphasize was that without predisposing factors, the trauma would have difficulty actually inducing pathology.
Yeah, I understand.
This is from the numbers, from the proportions.
There are the predisposing factors. There is context. How was my day before that event, etc. And there are genetic factors. How would you rate the context?
There's education, there is religion, there is...
That's the context, isn't it?
It's part of the context, but it's also part of the level of responsibility you have in an experience, etc. There are many factors actually that level of support, social support that you may receive or not receive. The many factors could contribute to this, and it's not so trivial to kind of dissect the influence of it. That is why it's a bit of a complex field.
Okay, but let's see what can we sort of analyze in an unbiased manner, because a person can describe its context differently, or different people will describe their context differently, and perhaps not describe everything. But the genetics can be sort of analyzed in an accurate manner. So are there any kind of genetic screens for individuals?
I'm sorry that I have to be difficult. As I said, the genetics influence is certainly part of what happens. But, first of all, many genes may contribute, and not the same genes in every person. And there are interactions between different phenotypes that the genes create that could lead to the fact that in one person this gene is not relevant, and in another person this same gene is relevant because it interacts with another gene. But what can be said is a kind of a more categorical statement. The maps of the genes have an influence, but even identical twins are different in their sensitivity, and identical twins have the same genetic map. The reason is that from the moment we are created, our genes are a kind of a possibility, and the way our cells use the genes is influenced by experiences. And you have plasticity, and you have epigenetic mechanisms, etc., which...
Wait, you're throwing terms that
okay,
we have to explain.
So you have the genes. This is like an instruction book. And then the way the cells would use this instruction book may differ according to experiences. So the same identical twins have the same book, but one of them is reading chapter A more frequently and the other is reading chapter C more frequently, then the biochemistry and the physiological responses they would have would not be the same. So that genetic mapping would give us a very partial and inaccurate outcome as to describe the individual and the susceptibility. You need to go higher. You need to go closer to how the genes are used. So you need to measure mechanisms that control the use of the genes. You need to measure.
But can we do it non-invasively?
First of all, it would be invasive, but the level of invasion can be tolerated.
Like a blood test will be less invasive.
So exactly. So you can do the blood test, but it's like looking under the lamp. You look at the blood and you want to look at the brain. So this is the status of the current research in many places. But it's not great. It's because you need to have the joint development of several methodologies. You need to have a more powerful ability to analyze many variables like big data, etc., artificial intelligence. You need to be able to collect data, and this has been a very recent development, the recognition that I cannot use averages of groups to analyze. I need to go individually because of the subjective nature of the phenomena we're talking about.
And that would be personalized medicine.
That would lead to personalized medicine, but before that would be personalized biology that would lead us to understand these phenomena. And these tools are starting to develop and to be available for us. And the more we have them, the more we realize that what we tried to do before was almost hopeless in terms of being able to understand.
That's unfortunate.
No, you could see big factors, like very, very significant factors. That's why I say that, for example, adversities in childhood are probably big enough so that even with our very limited tools, we could see consistency.
But you know what? This is a good opportunity to try and understand why it is this time or window, ages say 5 to 10 or 5 to 12, why is this time or window of opportunity, let's say, is critical? What happens in the brain during that time that leaves us more susceptible to future PTSD?
I think that, first of all, some of this is known to us. So because there are some brain regions which we know, as I said, from kind of imaging, etc., that are important for our coping ability, for our stress responses, etc., which are still developing at this age. And so they can be affected in a significantly functional way for the future. And I would say that because we see a similar effect in animal models, we know that these kind of biological effects are very significant. But in humans there is an additional aspect, and this is the kind of the social interaction with the environment, which could very much shift an experience from very negative to strengthening.
But why is it relevant for this particular age?
Because at this age, what is childhood? Childhood is actually the period that you build your strategies, your behaviors to cope with life, right? We have this childhood to prepare ourselves to being adults. So you build your tools, and if you build certain tools, it will be very difficult actually later in life to change those. You have mechanisms that are devoted to plasticity of your behavior during childhood. This is what childhood is for.
Let's just define plasticity.
Okay. The ability to change or to acquire skills and strategies, social strategies, etc., is very developed in your childhood, because this is what this period is for. It is, we are under the protection and care of our parents because we are not ready for life, and we need to kind of build the tools for being ready for life. Just one more sentence. If you look around the world, now we talk about children of 30 years of age, but at about the age of 15, you're supposed to be ready for life, right? So if you think about it biologically, in earlier days in modern societies, and actually already also now in other societies, people around the age of 15 can build up families, can start like their grown-up life. Which means that before that, you have a period which should be devoted to building the tools for later on, right? And we are geared for that, and our brain is geared for that. And if you mess up then, this is what you go to adulthood life with.
Focus naturally on factors that make you more susceptible to PTSD, but are there factors that make you more protected from PTSD? Are there any factors that are known to do that?
Sure. First of all, some experiences and education could help you. We said childhood is about building up tools for life. So helping you to build up these tools.
So education in early years.
Education, experiences, and being protective but not overprotective, so that we know, it's very trivial things. We know that a child needs to experience both positive but also negative things and see that they can cope with. This is a very important lesson, that you could have something that you failed in or that was difficult for you and you managed. Or you didn't manage, but it's not the end of the world. This is a very important lesson for life. So these are tools that actually help you by experience, by education, by support.
Is there any kind of difference or gender difference in the susceptibility to PTSD? Are there more males than females? If we normalize for experiencing war-related events that mostly men generally experience, etc.
with depression, there is more consensus that women are more susceptible to developing depression than men. And even there...
stress-induced depression, not major depression.
No, actually it comes from major depression, but also with PTSD, I would say that the weight goes towards thinking that females are more susceptible in a way. But I'm not sure that this is the best way to look at it. Because first of all, we have to remember, we talked about it at the earlier stages of this podcast, the diagnosis that we have is not an absolute tool, and the way we diagnose is dependent on a set of criteria that we have defined. So that you could imagine that if you define criteria that fit more symptoms that may appear more in females than in males, then more females would fall into this category.
So is this the situation?
Why am I saying that? First of all, there are already publications and reports that, on average, the symptoms that women complain about are somewhat different than the symptoms that men complain about as the major ones in depression, in PTSD, etc. Secondly, you have, for example, maybe more women who develop post-traumatic depression or post-traumatic stress disorder than men, but you have more men that develop some kind of syndromes like aggressiveness, like drug addiction or things like this, which may be biologically the same disorder, but manifested in a different way because of the basal differences between men and women.
Maybe also cultural differences.
Cultural differences are also important, but we have done some work with animal models, and we could clearly show, for example, that there are some aspects which are very similar between the sexes. For example, childhood adversities would lead to a higher proportion of affected individuals in both males and females.
Okay, that's important.
But what are the symptoms that they would show would be different. And we are now going into the brain, so we see that the changes that we can identify in those who are affected compared to those who were exposed but not affected and compared to controls are different in males and females. So that I think that we would need eventually to develop a different set of criteria for women and different set for men, different categories.
And it is not the situation as of now.
No. Now,
that's amazing.
Yes, and I think it is something that would need to be changed.
This is amazing. How far are we from that kind of change?
I think that such changes occur over years. But for example, until something like 20 years ago, nobody pointed to the fact that most of animal model studies were done in males and not in females.
That's another
and
problem.
in the last 15 years, and increasingly so, there is a requirement that people would work both on males and females to see the differences or the similarities. The funding agencies that fund research,
yeah.
they want to see the comparisons. So it is increasingly getting into the system. The awareness is there already. The requirement is going into the systems. And I think that the results would lead, naturally, to the need to differentiate between
symptoms in women and men.
Yes, and we have just to be very careful that these differences that we point to would not be translated to value. You know, it's not that men are more or less important or significant than females or than women, because we have this bad tendency to give values to the differences. No, we are a different system, men and women, and because of that our biology, our physiology is somewhat different, and we need to address that, but equally to assume equal importance to both.
So this actually leads me the actual amazing to me difference in diagnosis between men and women that seems to be understudied and poorly clinically assessed. This leads me to the topic of therapies. Say a person went to a psychiatrist and was diagnosed with either the stress-induced depression or PTSD. What can be done? I mean, what can the psychiatrist administer to that person that will help him, if it helps?
So first of all, the reality is not excellent.
Again.
The reality is that the treatment we have do help some individuals, partially help some individuals, and do not help others. And
so some numbers on that?
Yes. In major depression, where you have maybe the best statistics, people talk about something like, with all these SSRIs and all those drugs, that antidepressive drugs.
What are SSRIs?
SSRIs is a family of drugs, antidepressant drugs. The most known, I think, is Prozac, but you have many others of the same family. And when they started to come out, people thought that, okay, now we can, we can treat depression. But the numbers show that something like 30% of people who suffer from major depression are very much helped by those drugs, can come back to normal life, etc., with the help of the
30%.
30%. Something like additional 30% are helped, not completely remission, but they are very much helped, and something like 40% of the people are not helped by those drugs, and even when you try different drugs, etc. Now, because this is a disorder or syndrome that affects tens of millions of people, 40% are tens of millions of people. Now, and if you talk about PTSD, the situation is even worse. So I want to say two important things about it. First of all, psychological treatments are quite helpful.
Can this be interchanged with behavioral treatment?
Behavioral treatment is what I call psychological treatment. So these are actually the leading treatment in PTSD.
The leading treatment, okay.
Because they are more effective on the average than pharmacological treatment.
Like how effective?
Something like maybe 50% of the patients could respond and could be helped by psychological or behavioral treatments. But
50% of PTSD
patients. So they are considered to be more effective in a way. But I think that we should remember that talking about averages here is not the best way to look at it, because if I have a single individual for whom some drug treatment is very helpful, for him it's 100% helpful. I should not put him on the average of the other that are not helped by the drug. I should not say this is not an effective drug because I take, even if, for example...
Wait, but we didn't speak about drugs for PTSD. You mentioned drugs
I mean
for...
medications, like the antidepressant drugs. The main drugs that are used for treatment in PTSD are actually the same that are used for major depression. So These are like SSRIs, the Prozac, etc. These are the main drugs that are used also for PTSD. We don't have selective treatment as yet.
So just to be clear, the same drugs that are administered to depression or major depression, which isn't related to stress-induced depression, the same drugs are being given to PTSD.
Yes.
Which in a way suggests that there are common mechanisms in the brain. No?
It suggests that this is what we have available. So behavioral therapies are in numbers or more effective than pharmacological treatment. Okay? This is if you do the averages. But I want to put a word of warning that averages are not the best way to look at it. So cognitive behavioral therapy, exposure therapy, these are like the first line treatments for PTSD. Okay? And they help quite a significant number of people who suffer from PTSD. And for those that this kind of treatment is helpful, this is excellent. There are people who are treated with SSRIs, for example, in PTSD. And in general, this is considered to be a less effective treatment. Only maybe 20% of the people are helped by it. But for a single person, if the drug helps him, or if cognitive behavioral therapy helps him, this is 100%. So working with the averages is not the best way, and more effort should be put into trying to understand what is it and how can we identify those individuals that could be helped by cognitive behavioral therapy, exposure therapy, this drug or that drug.
What is exposure therapy? Exposure
therapy is a kind of a treatment that works with the patient under controlled psychiatrist or psychologist attention to go back to the experience, to come up and talk about the experience and actually build up the narrative in a slightly different way so that the person would learn that he is not accused of anything. Many people have some kind of feeling of guilt. So he's not guilty. It's normal to feel what he felt, etc., etc. And then you can build up a way that makes it possible for those patients to learn to cope with the trauma they have. And
how prevalent is this kind of therapy choice?
That's another thing with psychological treatments. They are normally very expensive, and many people do not have access to that. But with exposure therapy, there is a process of screening that they make, which is there is no clear-cut description of who would fit or who would not fit, but they do try to identify people who they think could work better, and then the people that they select have a higher percentage of success, which means that there is something that they can identify, even if not perfect, that kind of categorizes those people, even if it would be, these are the easier cases of PTSD. Okay, so let's say the easier cases we could do with that. People who have more depressive symptoms, or people who have a genetic mapping of some sort, or people who have epigenetic markers, they could be helped by that. And others, if we could have some kind of this personalized treatment that would enable us to identify which treatment would suit which individual, we would go a long way.
But we're still not there.
No, we're certainly not there. At the moment, everything is kind of trial and error.
That's unfortunate. So basically, there are several types of options or therapeutic options. There is the pharmacological option, which was borrowed from major depression treatments. There is exposure therapy, and there is the behavioral therapy.
And now there is the coming of a wave of using recreational drugs of sort, like hallucinating drugs or like
there was a publication
cannabis.
recently about a clinical trial. I wrote about it on my Facebook page. It was MDMA, and it was quite effective. It was in combination with behavioral therapy, and it was more effective than just behavioral therapy.
So, and of course you have many people who suffer from PTSD who use cannabis of all kinds. First of all, I think that the return to such psychoactive drugs is mainly because we could not produce something better as an alternative.
Yeah.
Yes. And I think that the effort should be going towards that. And why am I saying that? Because if it would have worked perfectly, that would be wonderful. But there was a reason for why society moved away from psychedelic drugs.
Was there a reason?
There was a reason. The reason was that, and the reason that there is a problem with treatment as such, with users as such, is that if you can, and this is what normally cannabis seems to be doing, cannabis seems to reduce the suffering of the person, which is very important.
Suffering in which respect?
It means they sleep maybe better, they have less anxiety, they feel a little bit more relaxed,
so
and so on.
So it's a symptomatic treatment.
Yes, but most of those people do not actually come back to be functional, do not come back to build the relations, do not come back to work, do not come back to be able to function in society, which is what we want to have as a kind of recovery, right? So the fact that we can provide something that would reduce suffering from these patients at the moment is very important, and I wholeheartedly support it. But it should not be seen as we have succeeded.
So if I understand you correctly, you're saying that psychedelics or cannabis kind of family of compounds can affect symptoms, but at the risk of not being able to bring back affected individuals to normal sort of work-related lifestyle.
This should be like the aim. The aim should not be just reducing the suffering, although it is a very important thing. But the aim should be to be able to, like in other traditional medicine aspects, to bring the person back to functioning. I just want to emphasize one more point. You mentioned that study was done in combination with behavioral therapies. So it could be that a controlled use of such drugs in combination with another treatment kind of open doors, if you want, for being responsive and attentive to behavioral therapy and helps the success of the behavioral therapy. That's fantastic. This means that you found a use for the drug that helps the therapy. It's not the drug itself that makes the change. It's that it enables the other treatment to do the work. That's fine. It is just like using, animals to work with autists and so on, so that you use some tools that help the person to open up. And then you use actually psychological treatments or something like this to treat them.
I remember that in that study, the authors of that study, or that clinical trial actually, mentioned that the combined treatment of behavioral therapy and hallucinogenics removed more people from the definition of PTSD, so they no longer stood in the criteria for PTSD. Isn't that sufficient to suggest that they are back to the normal kind of life that we expect them to?
Sufficiently back, let's say. They are sufficiently back. It's not. I know some people who do not fall into the category of PTSD, but do not sleep at night or have some nightmares and so on and so forth.
So they have partial symptoms.
They have partial symptoms, subclinical symptoms. As I said, the diagnosis is a more legal kind of a description. But But if it is sufficient to bring them back to relations, to work, to society, etc., that's wonderful. But what you indicate is that this is come as a combination. Just the drugs by themselves are not so likely to help most people.
With PTSD.
With PTSD or with depression. But they actually can cause, by themselves, some kind of reduced motivation and reduced functioning, etc. So that...
Is that proven by studies?
It depends on, even with cannabis, it depends on how intense and how much you use. If you start to use, let's say, cannabis, if you use from time to time social interactions, etc., just like wine, like beer, it's nice. Yeah, it's nice. I don't think that there is any problem with that. But if you're careful not to drive, if you're careful not to, try to be both at this kind of a sensitive task like a pilot or something at the same time, then why not enjoy it? But if it starts to be a very significant part of your life, it starts to consume the time that you have to do other things, and it starts to be a task, an aim of its own, then it actually moves you away from doing what you wanted to recover for. And what you see is that many of the PTSD patients spend a lot of the day not being completely communicative or interactive because they are under the influence, which at current situation is excellent because they do not suffer also. But it's not what we are hoping for.
It's not the ideal situation.
Yes, we want them to be able to be social, we want them to be able to go to work, we want them to be able to enjoy life, not to be able to escape from life.
So we're nearing the end of this podcast, and I want to hear your personal sort of view of the field of stress-induced PTSD or stress-induced depression, or all the kind of adverse outcomes of chronic stress that we mentioned in the beginning of the podcast. What is your vision for what kind of therapies or mechanisms, or when will our understanding be significantly more complete, and as a result we will see effective therapies?
I think that as we mentioned a lot in this podcast, it's a complicated field because we talk about very interactive and complex systems that are involved. We talk about large individual variability. We talk about the interaction between the individual and the environment, which could be very different and could influence the outcome, etc. We are in the beginning of an era that takes into consideration those complexities. Until recently, we tried to simplify things to the level that we could work with. So we looked for the gene of PTSD, we looked for the biomarker that would enable us to have a biological diagnosis. Now it's clear that it's not going to be a single gene, it's not going to be a single biomarker, it's not going to be a one-for-all drug. And we are building up the understanding, we're building up the tools to work with those understandings, both at the level of research and at the level of personalized medicine, if you want. And I think that this would be what would bring a better solution, and I would expect that in 10 years' time.
10 years.
Yes, I think that I can see that the tools are being built up, the understanding is already there, and I think that the technology is not actually the limiting factor, but our ability to kind of employ it in the right way is what is missing. Because, you know, a person goes out for jogging, he's all equipped with equipment that monitors him in a way that is better than many of the psychological labs or physiological labs. So you could monitor a single person, an individual person, you could follow up for a long time, you could have a good kind of picture of what happens to that individual, and you could slowly build the tools and the algorithms, etc., to use that to characterize that person. And then we would learn what the matching between different treatments and different persons. That would lead, I think, to a significant difference in the ability to treat those disorders. So I'm quite optimistic.
So along with that optimism, do you, as someone who is familiar with what the pharmacological companies are doing, or that kind of effort in clinical trials, is there a significant effort being done into clinical trials on stress-induced PTSD?
That's an easy answer to say. No.
No, okay.
What happened is...
That's unfortunate.
It is. And this is one of the things that need to be changed. Something like, you know, I can give you an exact year. In 2010, the head of the NIMH, the NIMH is like
National Institute
of Mental Health. It's like the largest organization that works on research of mental.
In the US.
Yes, but no, in the world. Actually, it is in the US.
Yeah,
but
I just wanted to mention that NIMH is part of the National Institute of Health. That's in the
US, but it's a big. So, the head at that time of the NIMH indicated that the large pharmaceutical companies move away from trying to develop psychiatric drugs because of the lack of success, because of the complexity of the field, etc. And in fact, all the medication we have today is based on findings in the 50s and 60s of the previous century.
Including Prozac.
Everything. And it's the same idea, the same concepts and so on. We don't have, at the moment, new ideas, except bringing in those psychedelic drugs and so on, which is like, that's why I said that this is actually a result of a failure. Now, one reason why those companies, and since he said that, when he mentioned it, there were two big companies. Now all the companies actually have moved away from even aiming to develop those drugs. And the reason they did it was because we were completely focusing on trying to find the answers to the simple stories we try to work on. And the lack of success in this direction led the companies to move away, but also led the field to change the direction. And now there is another heavy mission for the research field, and this is to persuade big pharmaceutical companies that we now have significantly better tools to address those disorders, so that there would be a good enough reason for these companies, which are businesses after all, to come back to aiming to develop new drugs.
So on one hand, you're saying that in the last 10 or more than 10 years, there has been a withdrawal of pharmaceutical companies from investing in R&D, research and development, as well as clinical trials as a result. But on the other hand...
In psychiatry.
In mental health, psychiatry, in the topics that we discussed. But on the other hand, you're quite optimistic that in 10 years, we will have a significant breakthrough in
Because
therapy.
The breakthroughs that I'm talking about in 10 years do not depend on developing new drugs, but on having better usage of what we already have, and in parallel, developing the basis for a new effort for research and development of novel drugs.
Okay, that's thanks for the clarification. So I think with that we will conclude. Really, I want to thank you for your time.
I want to thank you. You should come more often. It's a
will.
very enjoyable discussion we had.
I will. It's been very interesting, and I hope that that people at home will sort of continue discussion of the topics that we raised in the comments, and if there will be some interesting points, we can continue the discussion offline. So thank you, Gal, and thank you, and see you on the next podcast.
Thank you, everybody who would listen.
Yeah, pleasure.